video, we'll see in detail about imaging in renal trauma, how to approach a trauma patient from the initial ER till the management, and also AAST grading recent updates. We'll discuss it under following headings. First, we'll discuss the role of imaging workup in renal trauma, then in detail about USG FAST procedure and its limitations, CECT protocol in renal trauma, then most important part of the topic, AAST grading, that is recent update of 2018 in detail, role of angiography and management and sequelae in cases of renal trauma. This we'll discuss in this video. Once the patient comes with suspected renal injury, imaging workup is required. Why is it required? To assess severity and extent of injury, to rule out any associated injuries to other systems, to see the function of kidney. And we use the following modalities. We can use ultrasound, which is bedside, and we can do fast protocol of ultrasound, and we can use CECT for renal. When do we take up the patient for imaging in suspected renal injury? When there is gross hematuria or when there is microscopic hematuria with hypotension, when there is direct injury to flank like contusion or hematoma over the flank, or rib fractures in mainly the lower ribs, or any transverse process fracture involving the spine. Next indication will be penetrating trauma with any degree of hematuria. We have to do renal protocol of imaging. First and the most important modality will be ultrasound, which can be done bedside in emergency settings. That's the initial assessment. We have to do the FAST protocol. FAST stands for focused assessment with sonography in trauma. FAST. So this will give us an overview of free fluid in the abdomen. Also we can see or rule out gross visceral organ injuries in emergency setting itself. It also is used for guiding the triage for the patient. How is ultrasound fast done? We have to scan the following areas. First, we have to look at pericardial or epigastric region by keeping the probe in midline. Next, the right flank and the left flank. Next, we have to assess the pelvic or suprapubic region by keeping it in suprapubic region, the probe. Now we use extended fast or E-fast, where bilateral pleural cavities are also assessed. Ultrasound fast has its limitations, which are the following. We may not be able to identify the source of bleeding in ultrasound, and this may require extensive effort to look for parenchymal injuries, especially if there are small injuries. Next, it is hard to detect free fluid if the fluid is less than 250 ml. It's also difficult to assess the retroperitoneum in ultrasound. Also, it's very difficult to assess any injuries in obese patients. After ultrasound, the next important modality or the gold standard will be CT scan. CT scan has both increased specificity and sensitivity in order to detect renal injuries. So what do we see in renal CT scan? We have to look for extent of injury. We have to look if there is any perirenal collection. We have to look for urine extravasation. For that we use contrast CT or CT urography. Also we should look at vascular pedicle injury of the kidneys. Coming to the protocol of CECT in renal trauma patients. First, immediately the non-contrast images of the sequence has to be taken. Then give 100 to 120 ml of IV contrast at 2 to 4 ml per second speed using a pressure injector. Next, first sequence or the first set of images we take at 70 to 90 seconds delay after giving the contrast. Second set of images we take at 3 to 5 minutes delay. Next, this is used for pelvic ileal system assessment, and the first images were for the parenchyma. Next, we may or may not use a delayed sequence which can be taken to rule out any periureteric fluid. This is taken at 10 to 15 minutes after the contrast. To AAST grading, AAST stands for American Association for the Surgery of Trauma. AAST guidelines for renal injuries. This was last updated in 2018. I am going to discuss the updated or the most recent grading of injuries. There are 5 grades, and imaging should be done in dual phase in order to grade it. In grade 1 we have subcapsular hematoma and or contusion without any laceration to renal parenchyma. Here the capsule, here is the subcapsular hematoma. We'll see how it looks on CT. In CT we can here see the renal parenchyma intact, enhancing well. We can see the subcapsular hematoma surrounding the posterior aspect of the kidney. This can be managed conservatively. Coming to grade 2. In grade 2 we have superficial laceration to renal parenchyma less than 1 centimeter deep. There will be no involvement of the collecting system whatsoever in this grading, and the perirenal collection or hematoma will be confined by the perirenal fascia. Now we'll see how this looks on the CT scan. We have sagittal and axial images. Here we can see superficial laceration less than 1 centimeter deep with perirenal collection, which is confined within the perirenal fascias. Coming to grade 3. In grade 3 we have laceration which is more than 1 centimeter deep, but there is no involvement of collecting system even during this grade. Next we can have vascular injury to any segmental vessel or active bleeding which is confined within perirenal fascia. Here we can see laceration which is more than 1 centimeter deep. Now we'll see on CT how it appears. On CT here we can see the laceration which is more than 1 centimeter deep and the collection or bleed within the perinephric fascia which is confined again. On non-contrast CT this is how it will appear. Coming to grade 4. In grade 4 we can have laceration involving collecting system. So collecting system involvement starts from grade 4 with urine extravasation, or there can be laceration of renal, pelvis and or ureter at uretropelvic junction, or we can have injury to segmental vessel in kidney, or we can have segmental infarctions with no active bleeding. This also comes under grade 4. Now active bleeding extending beyond the perinephric fascia also comes under grade 4. So if it is confined within perirenal fascia, it comes within the grade 3. If it is extending beyond it, then comes to grade 4. We'll see how it looks on CT. In CT grade 4 we can see here the laceration is extending up to the renal hilum, that is involving the collecting system in this image, and there is urine extravasation. This can be seen on contrast enhanced CT. Now we have the last grade, that is grade 5, which you all know. It is the shattered kidney. It can also involve avulsion of renal hilum, that also comes under grade 5, or there can be laceration of main renal artery or vein. This also comes under grade 5, and devascularized kidney, also grade 5. On CT here we can see the shattered kidney, and here we can see renal artery avulsion with confined bleed. Both are different patients, different images coming under grade 5. This has to be surgically managed. What is the role of angiography in renal trauma? There will be better delineation of vascular injury which can concurrently be managed on the same table by angioembolization. So this is both diagnostic and therapeutic at the same time. Moving on, we'll discuss briefly about management. Grade 1 to 3 can be managed conservatively unless there is any active bleeding or life-threatening bleeding which is present, then it has to be managed with active intervention. Grade 4, if there is more than 50% tissue damage with or without urine leak, and also grade 5, both has to be managed surgically immediately. Sequelae to renal trauma, there can be permanent parenchymal damage which results in scarring. There can be abscess by superimposed infection. Hypertension can occur, that is known as Page kidney, where there is long standing compression of the renal parenchyma by the subcapsular collection, which will activate renin-angiotensin system. Follow our page on YouTube and Instagram for more such videos. Comment if you want any more videos. Thank you.